Sorry I'm a little late today. Let's try and make up some time here. Just pregnancy perinatal stuff today, and I'll do kids next week. Okay, so let's get started here. Kind of separated this in a couple different topics. Start with some quick slides on fertility. I don't have a ton to talk about here, but there are some drugs used specifically for fertility. So if that's an area of medicine you decide to go into, it's worth just including it. But there are, again, a couple of things we can talk about. And certainly there's surgical options and other technologies out there that exist beyond the scope of pharmacy, of course. A couple different classes of infertility that exist out there. The most common being the second class there, normal gonadotropic, normal estrogenic, meaning that hormones are generally normal. When the hormones are normal, it's difficult to manipulate that aspect of it, obviously. So that makes it a little more challenging from a pharmacologic standpoint. So that's really why I'm showing you guys this. I don't really care about the differences or that you know them for my test or my class. Reminder of how everything works: hypothalamus, pituitary gland, luteinizing hormone, follicle stimulating hormone, and the feedback loops and mechanisms that I'm sure you guys have seen in pathophys and many other places in your career so far. All right, let's talk about the drugs. So a couple things we can do if you have ovulatory dysfunction, which is a relatively common thing. You can treat it by inducing ovulation. This is relatively easy to do, especially with the drug clomiphene or Clomid. Clomid's fairly cheap. It's an oral medication that you can take, and you only take it for a couple of days, and it's either going to work or not. But it's, anyway, a pretty easy option for a lot of patients who are trying to get pregnant. So it's a SERM, kind of like tamoxifen or aloxifene, like we talked about. Again, just a different group of estrogen receptors it's targeting. So it's an estrogen antagonist and agonist effects that end up causing an increase in gonadotropin release and kind of like a surge in luteinizing follicle stimulating hormone. So you do 50 milligrams once daily for 5 days. And if that doesn't produce ovulation, you can try again for 100 milligrams 5 days for an additional course. And you may start another course 30 days after completing that first one. So you can reuse clomiphene. I'm not sure if going beyond 2 courses is ever really recommended at that point. I think it's kind of like you tried it and let's move on and try something else. Timing is important, so intercourse should be timed 5 to 10 days after the course is completed, because that's about how long it should take your body once you manipulate the hormones a little bit to have a successful ovulation. Generally effective for WHO class 2 only, but that's the most common one. And may cause development of large ovarian cysts. It's really the only side effect. That's probably for people who take it multiple courses at the higher doses. I imagine 1 course probably wouldn't do that, but it's possible. So again, that one's pretty basic, relatively inexpensive option. Gonadotropin therapy, Menopur or Repronax, again, purified combination of follicle stimulating hormone or luteinizing hormone. Just by nature of this product and the extraction method, it is actually a human hormone that's extracted from urine of postmenopausal women. So because it's difficult to obtain and purify and all that stuff, it is quite expensive, as you might imagine. It does require some monitoring. And but it could be useful for class 1 and class 2. So. And it's going to cause the same effect basically as clomiphene, right? It's going to increase the hormones, going to hopefully induce ovulation. All right, some more ovulation-related mechanisms you can try. Metformin actually has been linked, especially with patients to polycystic ovarian syndrome, to promote fertility. So that's an option certainly to try in those patient populations. The live birth rates are not as high as with clomiphene, but the reason why I think this happens is that the patients might lose some weight from increased glucose utilization, which might make them more apt to facilitate ovulation. That's the theory behind the mechanism. But otherwise, it doesn't really make direct sense. It's kind of the oddball when we're talking about these drugs. Most of them manipulate hormones to a certain degree. This one obviously doesn't. Aromatase inhibitors, talked about these a bit last week. These have limited data for WHO class 2 patients, but they might produce fewer follicles and lower estrogen levels than clomiphene and shorter half-life. So they aren't FDA approved for infertility. It's not thought that they're necessarily better than clomiphene. So they are an option possibly for somebody who's failed clomiphene to try, but it's not necessarily something that we know for sure works. There's minimal evidence for it, and it's not FDA approved. And they're generally pretty expensive medications. So again, I wanted to mention because they are used in this area, but for the most part, we do not recommend them over like a standard clomiphene treatment regimen. Vaginal progesterone. So this can be given as a gel suppository tablet. It's just a steroid hormone, so it's the same thing as the naturally occurring progesterone. So this isn't an analog like we talked about last week when we talked about contraceptives. The mechanism with respect to reproductive therapy, so we can use this in the luteal phase, and it supports embryo implantation. And so again, this is local. It should have fairly minimal systemic side effects that way, and it's another strategy you can try.
Awesome. Very good.
I didn't know that. There you go. And with that, that's all I want to talk about with fertility. So there's, again, only a few pharmacologically useful things that I think are worth talking about to a general audience. Of course, if you worked in fertility, you might get into the weeds a little bit more on some of that stuff, but here's a little intro for you. All right, talking about drugs in pregnancy and lactation. Very briefly, I've brought this up throughout the course. We've talked about pregnancy preferred options and lactation things. I've tried to include it in areas where it might be more common for a younger woman to use certain medications, but certainly you can encounter all types of situations where medications will come up, and it's like, you always have the question, is it good in pregnancy, not? It's difficult to keep it all straight. There's some things that, some areas you'll work, and you'll get so familiar with certain medications that you'll know right off the top of your head, yep, this is well studied in pregnancy, or this is preferred in pregnancy. There's a lot of other options out there that just have very little data to support it. And the reason is ethically inappropriate to do trials on pregnant women, right? So usually a lot of times we're looking at retrospective analysis, and sometimes we're pulling data from large groups of populations who have undergone pregnancy and had medications taken concurrently, like in European data groups where they have access to large pools of information. But again, very few what we consider like high quality trials done on pregnancy patients and lactation as well. So again, the data is kind of all over the place and not high quality, and especially with new drugs. New drugs, you probably aren't going to see anything. So even if a new drug might be great in pregnancy, really safe, like let's look at anticoagulants, for example. Some of the new factor Xa inhibitors might actually be really preferred in pregnancy compared to some of the current options we're using, but we just don't have the evidence to support any of that yet. So those will take time. A lot of the times when you're talking about using specific agents in pregnancy and lactation, it's older medications that we have more experience with and that we know are safer overall. This is a reference that I'll point out. Have you guys heard of this book before, the Briggs reference? Anybody brought it up in a class before? It's one of the only paper books I actually like. I use most electronic reference now, and this actually comes with an electronic version as well. But if you do work with a lot of, or you find yourself asking yourself this question a lot, I get this question from my providers a ton about pregnancy and lactation. But of course, not everybody has somebody who has this book in their desk ready to look it up and interpret it. This is a really good one, and it just gives you so much more information than just looking at an FDA letter category or a basic drug monograph. It'll give you clinical trials, evidence. It gives you sort of an overall rating. It says it's compatible, mostly likely compatible. It'll give you quality of evidence and what the trials look like. It'll go through some of the trials in detail in a very nice summary that's very easy to read and interpret, I think. So again, if you find yourself asking your patients, or your patients are asking you this a lot about, can I take this in pregnancy? Is it safe in pregnancy? Can I take this while breastfeeding? I highly recommend this reference. It's been a lifesaver for me in a lot of situations. Okay, so FDA pregnancy categories are actually on the out, but they still are representative for the majority of medications on the market. We have a new classification system that the FDA incorporated a couple of years ago, which I'll talk about here in a second. But the majority of things are still going to have your traditional categories tied to them. Old drugs are basically grandfathered into this new process, so only new drugs are going to undergo the new FDA guidelines for pregnancy descriptions. But the old categories you're still going to hear used a lot. Oh, it's category B or A or C. What does that mean? Well, category A is essentially non-existent. There's very few drugs that are actually category A. We'll talk about one of them, one combination here in a second. But there's very few drugs that have undergone controlled studies in pregnant women and have shown no risk in the first trimester. Again, we just don't do studies like that because of the ethical risks. Category B is animal studies show no risks, or human studies, or humans show risk, or animals show risk that isn't confirmed in humans. Sorry, I'm getting my categories mixed up. So we've had good animal data to say that it's likely safe, or the animals data maybe showed risk, but we haven't seen anything translate over into humans. Again, that could apply to a wide variety of medications as well. C is probably the most common one we're going to see out there. That's the most nebulous, I would say. It's animal studies show risk. Caution is advised. benefits may outweigh the risk. And the big difference between B and C is that we don't really have this this confirmation or unconfirmation thing. So it's like, do we know that the animal studies might show risk versus no risk? And so that's the big difference there is animal models. And again, how well can we translate that to human trials? Probably not super well in a lot of cases, but sometimes it's the best you have to go off of, especially when it comes to new drugs. D, evidence of risk to human fetus. Benefits may outweigh risk in serious conditions. Mostly you're going to avoid category D medications of pregnancy, but again, you might have a situation that a patient a year ago or so on lithium. Lithium's category D, but she was stable on it and is controlling her, is an adjunct she's using for schizophrenia. So it was recommended that she actually keep on that drug at that time, even though it is category D. So you might see odd situations where category D is applicable, but generally we're going to try and switch somebody off of D into a different category medication if we know that there's something better they can take safely. X is generally known to be teratogenic, and there's no real benefit to using those drugs in pregnancy, or the risk is so great that any benefit would be outweighed by that risk. So high rates of teratogenicity with category X medications. Okay, so the new labeling was effective June 30th, 2015, again for new products. So labeling is supposed to be phased in gradually for current products. How the FDA is monitoring or regulating that, I have no idea. It seems like a pretty massive task. But I suppose eventually you're going to see more data being published or at least available to providers to look at that goes through some of this type of logic as opposed to just simply supplying a letter. Again, so gone are the old letters. So new drugs aren't going to have a letter category. And you're going to get detailed information within 3 specific categories. The first is pregnancy, second is lactation, and the third is females and males of reproductive potential. So that's a new one. Lactation data previously was sort of hit or miss whether the companies would report it, so now it's actually required to have some sort of lactation data on file. Females and males of reproductive potential, again, that was something we didn't see before, but you are seeing that now with the new drugs. They are supposed to be testing for that and including that in their recommendations, whether it's going to impact the reproductive potential of either a female or a male patient. And especially on the male side, that's a big thing that I don't think we've ever really seen a lot of studies done for many drugs. So again, how they're going to really phase it in gradually, I'm not sure, because it's going to be a lot of trials that somebody would have to do. Some of the data probably exists out there in small subsets, but again, who knows how this is going to get implemented or how long it's going to take for us to see some of this stuff translate to our older medications. Other information, difference in dosing. So if there is a recommendation to increase or decrease dosing during pregnancy, that's supposed to be included. And negative consequences of not treating a specific disease. So if the drug has maybe a potential risk, what's the consequence of holding it versus giving it? So it's trying to help providers make that benefit outweighs risk decision. The next 2 slides just show you some different international ways that countries have categorized pregnancy. Like if you go to Micromedics, which I know a lot of providers I work with don't use, it's more of a pharmacist thing, but it will show you the Australian categories too, and they stratify things a little bit differently, which I think is nicer. It makes more sense to me. So if I see something that's US category C, it might show up as Australian category B1, meaning that they've actually looked at some of the evidence and stratified it differently. And it just gives you a more rounded approach to it as opposed to C, which again is just very general in terms of our old FDA letters. So just an example, I won't test you on that or anything. Same thing with the German ones. Here's just an example of how Germany does it. So again, this is not, FDA lettering was not universal, so you can see why they went away from that and are incorporating more of a comprehensive system that includes just evidence and basic summaries and recommendations, as opposed to a letter category system. All right, lactation, it's pretty difficult to actually make a recommendation in some cases. And so the thing is that most drugs are excreted into breast milk. The big question is how much gets in. So a lot of times we're going off of certain trials that look at blood concentration versus breast milk concentration. Then there's lots of ways you can calculate to figure out how much might get into breast milk based on the osmolality of the medication, based on the molecular weight of the compound. It gets really complicated, and there's no way most providers are. I did this long CE about lactation last year, and they were having me do all these weird calculations. Like, no one's going to do this in real life. It's just the data, or not the data, but the information that you need to accurately calculate some of this is just not readily available in a lot of cases. So the point is a lot of them are excreted into breast milk, but the thing to remember is that how much is actually going to get to the infant depends on a lot of things. So first of all, the drug has to be absorbed by the mom, right? It has to get into breast milk. It has to be ingested by the infant, and then it has to get into their body without undergoing metabolic pathways as well. So the point is you lose some at every step, right? So you aren't going to, even if you can confirm that there's some in breast milk, you're still losing it by the time it gets to systemic circulation in the child. So my point is a lot of times it's very low risk to give a medication in a nursing female. However, there's still that risk. So a lot of times it might come down to saying to your patient, it does excrete into breast milk. There is maybe some risk of sedation or maybe delayed growth in some small trials, but it's a risk outweighs benefit. Do you want to work on a strategy to pump and dump with the patient? Do you want to have them hold off on breastfeeding altogether? We'll talk about some of that stuff. I think I've got another slide here coming up, which will elaborate on some of that more. But I always rule of thumb, if somebody's really nervous about it, they can pump and dump during the time. So sometimes we'll get people on a temporary course of something like an antibiotic. If they're concerned about that, they can consider pumping and dumping for that time period. If they really don't want to disrupt their breastfeeding with their baby, that's a totally different question. And then you might have to get a little bit creative about feeding times versus medication times and things like that. The American Academy of Pediatrics lists the following things as contraindicated. So they say amphetamines, antineoplastics, which are chemotherapy agents, bromocriptine, cocaine, generally drugs of abuse, ergotamine, lithium, and nicotine. That's their list. It's pretty small. Some of it's kind of obvious, right? Drugs of abuse. But for the most part, they don't say a whole lot of things are outright contraindicated in breastfeeding, which is sort of interesting. A lot of times, if you look at that Briggs book under lactation category, you'll see that they have recommendations on maybe it excretes into breast milk, and this is what the studies show. And then it'll say the American Academy of Pediatrics recommends XYZ. And I feel like they have pretty loose recommendations. Usually it's that they think it's compatible with breastfeeding. In most cases that they recommend it's okay. They do, however, say that a very small amount of things are relatively safe. So most moderate alcohol, actually, analgesics, antibiotics, generally anticonvulsants, moderate caffeine, insulin, and laxatives. Now that leaves a whole bunch of medications in the middle, right? And they'll kind of give a recommendation off of that, and we don't have good evidence to support it. So sometimes it's like you read the evidence and you say, okay, well, there's a couple small trials that say it excretes into breast milk, and at the end it says American Academy of Pediatrics listed as compatible. So you have to say, well, they thought it was good enough based on the evidence, so is it really? Or how would you interpret that information to a patient is really probably going to be your biggest challenge in explaining that, we don't have good evidence. Our best, well, one of I guess a well-respected, I should say, group recommends that it's okay. So you could explain that to your patient that way, but it still won't be uncommon to get people who are concerned about that. And it's just something you'll have to talk through on a case-by-case basis in a lot of situations. Some other things to consider and some tips. There's some drugs that can definitely decrease milk supply. So you might hear that certain things shouldn't be given. It's not necessarily because they're harmful for the fetus. It's because they can decrease milk production. So anything anticholinergic carries a risk. Benadryl, of course, being a notorious one. Although I think the evidence actually for Benadryl is that it doesn't really. I think it's maybe an old wives' tale of sorts that Benadryl actually decreases milk supply. Androgens, bromocriptine, again, here's bromocriptine back. Ergot alkaloids, estrogen products, levodopa, which we talked about last week, estrogen, levodopa, monoamine oxidase inhibitors, again, odd antidepressant, nicotine, pyridoxine, and sympathomimetic agents. Increased milk supply. Amoxapine is a kind of obscure tricyclic antidepressant. Antipsychotics, some of them can increase milk supply, but some of them actually are anticholinergic, so they might decrease it. So I'd put that one, personally, this in kind of the middle column. Methyl-dopa is something that is used sometimes for hypertension in pregnant patients, and that can help increase milk supply. Metoclopramide and reserpine, which is a really odd old antihypertensive. There's not a lot of drugs here that people take on a regular basis, so I'll put that out there. So I don't know if I'd go prescribing any of these specifically to help somebody increase breast milk production. I think that there is some herbal things that I don't know if you'll get to in other classes. I'm not going to touch base on them because I think that my wife went through all of this a couple times, and I think the evidence on the herbal regimens is sketchy, to be honest. Now, they get recommended. You have to take them in really large quantities, and one of them tastes a lot like maple syrup, which my wife hates. So that wasn't really an option for us. So anyway, the point is there's other options in this. I just want to point out that there are some drugs out there that are known to increase milk supply. And I'm not going to go through the specific herbal ones. Other tips. So drugs with short half-lives. The idea is once a drug leaves your systemic circulation, it's gone from the breast milk as well. So it's not like it just goes into breast milk and stays there. It will circulate out eventually as concentration gradients change. So a drug with a shorter half-life theoretically is not going to stick around in breast milk as long as a drug with a longer half-life. That's one of the reasons why, for example, let's use antidepressants. A drug like fluoxetine is not as recommended in pregnancy or postpartum because it's got like a several-day half-life, whereas a medication like citalopram or sertraline or paroxetine might be a little bit more preferred because they're shorter half-life. Administer the drug immediately after a feeding. So the idea is once you hit your Cmax absorption, you're going to be at the highest risk for infant exposure. So what you wouldn't want to do is breastfeed like 3-4 hours after ingesting a medication, because that's probably right where your blood concentrations are highest. You want to do it immediately, immediately before. So basically when your drug concentration's at its trough, breastfeed if you can. Now, that's not convenient if you're breastfeeding 5, 6, 7 times a day. So that again, challenges there with early breastfeeding versus long-acting medications, and how do you balance that? I think the best thing you could do in that case is to try and time it as much as possible with that trough period. So making sure that if the person has a time that they're going to maybe be abstaining from breastfeeding for the longest period, so hopefully there's some sleep involved there with the infant, they could do it right after the child goes down for the night, if they do go down at all. And infants use the drug. This is a nice rule of thumb I always think about. Do they use the medication for babies or for children? And if it's okay or has studies in children, it's probably okay in short amounts, in small amounts, short term for the infant. Again, some of this is you have to make a bit of a leap of faith because we don't have a lot of evidence, but using some of your judgment and discussing it through with your patient. And then again, looking at the risk outweighs benefit. How much benefit is the patient getting from this medication? How critical is it that they continue to take it? That's another question you need to ask. Yeah.
Let's say a woman is having difficult activity with milk, would they prescribe one of those medications to increase milk?
I don't know. Again, I think from what I've understood in talking to people at work, most of the time the NPs that will do lactation consultants, at least at our clinic, they recommend the herbal routes like fenugreek and some other things like that.
I've never seen that.
Yeah.
Usually, we monitor on fluid and nurse, importantly,
Yeah, certainly there's other non-medication or non-supplement things you could try as well. Okay. Any questions on that generally? For the exam, I want you to know the FDA letter categories and be able to differentiate between them, because I think they are still important even though they're getting phased out. You'll hear them a lot used in general conversation, and it's just good to know because they still show up on direct monographs. And then as far as other things, there's not going to be a whole lot more on that. I think understanding that certain medications might decrease breast milk supply. So, for example, anticholinergics, steroid hormones, those would be things that might be worth remembering. And we've talked about some of that already. All right. Moving on, talking about some pregnancy-related complications. So, oops, there we go. All right, morning sickness, common complication, nausea and vomiting associated with pregnancy, most common in the first trimester for most patients. Cause not necessarily known and thought to be linked to hormonal changes, like a lot of these complications with pregnancy, but not necessarily a sure bet. There's also something called hyperemesis gravidarum, which is different than just plain morning sickness. So that is severe nausea and vomiting leading to malnutrition and dehydration. Let's go ahead, Did I say something weird?
No.
Okay. Oh, so that's on the recording. Okay. Makes me nervous when people come in randomly. Okay. Hopefully I pass. Take a drink of water. All right, anyway, so severe nausea and vomiting leading to malnutrition and dehydration. I've had a couple patients show up to the ER over my career. It doesn't happen really often, and we do have a pretty I say high acuity birth center at Abbott, so I feel like I see this maybe more than the average hospital would. But this is usually not, I don't know if I'd call it a medical emergency. It can get that way though, certainly. And it just really is the building up of that nausea and vomiting where you can't have any intake. And then, yeah, it can definitely affect the development of the fetus. You want to make sure that patient's getting adequate nutrition. Whether that's enteral feedings, like via feeding tube possibly is an option. Getting IV antiemetics like we've talked about already. Or in the most extreme cases, I've seen people get parenteral nutrition where they're getting it intravenously. Which we'll talk about more during critical care a little bit. So anyway, if we're talking about just plain morning sickness, not just plain, if you've gone through it, you're probably like, it's not just plain, it's not pleasant at all. But there's some options we can do, certainly non-medical options, or non-pharmacological, I probably should say. Saltines, bland food, if it showed maybe to help, maybe not, I don't know. Typical kind of like old wives' tale stuff. But preventing the stomach from being completely empty, so a lot of women will get recommended to eat smaller meals over the course of the day as opposed to larger meals. Avoiding anything that's a trigger. So spicy, odorous foods may be a trigger for some, may not be for others. And then smaller meals generally. Some of that stuff has been shown to help, but certainly patients are all different when it comes to dietary habits, so is those going to be absolute rules? No. All right, so let's talk about what I know more about, and that's drugs. So symptomatic treatment. Okay, so the preferred category is category A. Actually, one of the only drug combinations I know of that is category A, and it's a combination product. Brand name is Diclegis, which is down here. And it's a combination of doxylamine and pyridoxine, which is this vitamin B6. Both these medications are cheap, over-the-counter, have been around for a while. Pyridoxine is, of course, just a vitamin. You can buy it, at any over-the-counter drugstore or whatever. And doxylamine is brand name Unisong. It's used as an over-the-counter sleep aid. It's kind of a weak antihistamine. I think of it like a weaker version of Benadryl almost, a short-term sedative. But the combination is category A. Whether it's effective or not is debatable. I think the evidence on it is pretty weak. However, it's pretty benign as far as side effects goes, except it might be mildly sedating. Other than that, it's not going to have any negative effects on the fetus. So from that perspective, it's a good first choice because of this. Now, my caveat here is not to prescribe Diclegis brand. Diclegis comes as a prescription product that's delayed release, that's expensive. I would just recommend your patient take over-the-counter doxylamine and OTC pyridoxine. That's what we do at the hospital. We split it up, saves us money on that end. I can't remember the dosing of Diclegis, but you can make it pretty similar with an over-the-counter combination. Not exactly what they do, but it's relatively the same. Okay, so that's only A. The category B options, meclizine, diphenhydramine or Benadryl, or diamond hydronate are both okay and generally thought to be safe in pregnancy. Metoclopramide, we talked about this a little bit, but that's one of the preferred ones in pregnancy as well, category B. And promethazine is also listed as category B. So all these have somewhat decent data, either in confirming that humans don't have any risk or that the animal models didn't have risk or something to do that they got category B on their label. Ondansetron is controversial. So ondansetron is category B. However, there were all these big chunks of evidence that came out saying, there was one big paper that came out looking at it. There's a big meta-analysis that said that Zofran has an increased risk of oral facial pus. A couple subsequent studies one kind of replicated their data, but was not statistically significant, and the other one said that it's no more likely to cause birth defects than placebo. So there's been some debate over whether ondansetron should be our first-line agent, because for years, and I'm going back to when I was in school and when I started practice, which was that long ago, it was always the first-line choice in pregnancy. However, within the last, maybe 2 years, 3 years, that's gone back a little bit. So I don't think it's not that. So I'll put it this way. This is how we look at ondansetron. It's fine to use, but you should try a couple other things first. So try your doxylamine pyridoxine combo. Try your Reglan. Try Benadryl maybe, and if those three things don't work, try ondansetron. That's sort of maybe a fourth-line choice. And again, certainly I don't think it's anything to be terribly concerned about, because I would say, after reviewing the evidence myself, I wouldn't feel uncomfortable if my wife got it when she was pregnant. I don't think she did, but if she was in that situation, I don't think I would have. It wouldn't have bothered me personally. So again, my opinion, but there is evidence out there that's a bit conflicting over the birth defects on Zofran, and it is a little controversial currently. Others, some options that could be a choice. Methylprednisolone as a steroid can help with nausea, and that's steroids in general are category C. Sorry, I should say glucocorticoids in general are category C. So like methylpred, dexamethasone, prednisone. And we don't really know if they have a huge effect. It's thought that they cross the placenta, but I don't think most of the evidence from what I've reviewed says that benefit outweighs risks in most scenarios. So you really need to try and control some bad nausea. Nothing else is working. A steroid actually might be an effective option. Same thing with migraine headaches, which we'll get to in a little bit here. Prochlorperazine, compozine's category C2. There's some iffy evidence on it. I think generally it's thought to be safe, but again, just a further down the line recommendation. So herbal, ginger, actually has some okay evidence with it. I had a friend who did a review on this, and either aromatherapy or oral ginger has some decent evidence with it. So it's something to try. If your patient feels nauseous when they smell ginger, obviously don't try that, but it could be an option for some people. We do use the aromatherapy ginger occasionally for nausea and vomiting in the hospital, believe it or not. Heartburn. Usually during the later half of the pregnancy, enlarged uterus, pressure on the abdomen and stomach equals more issues with possible epigastric reflux. So non-medical options, smaller, more frequent meals, avoid food, liquid 3 hours before bedtime, elevating the head of your bed. Similar things, same things we talk about with any patient experiencing some sort of heartburn or reflux. Symptomatic relief, most antacids are safe. In fact, I think they all are. Magnesium, aluminum, calcium carbonate, all acceptable to try. Unfortunately, those aren't sustained, right? So if you're getting very episodic heartburn that's maybe once a week or something, that's probably a great choice for your patient. If you are getting heartburn every day, that's probably not the best choice. So sucralfate, which is a 4 times a day medication, is an option that's safe in pregnancy. Remember that one? It just coats the lining of the stomach. It sort of has an antacid neutralizing effect as well. But the better choice is going to be probably an H2 blocker. Ranitidine is very well studied in pregnancy, and that's the preferred treatment. Famotidine, the other H2 blocker that we use a lot, is thought to be safe as well. It's just not as well studied. We have a lot of pretty decent data on ranitidine. Why that one specifically, I don't know. That's the one they chose to study. And again, when it comes to pregnancy, the one that they chose to study, even if it's likely that there's a better alternative or a similar alternative that works just as well, we always go with the one that they chose to study. PPIs don't have a lot of evidence in pregnancy, but they're thought to be safe for the most part, and they will use OBs will use PPIs in advanced cases of reflux not responding to H2 blockers. So certainly, I would say very likely safe, but again, minimal evidence to support them. All right, constipation causes decreased peristalsis, increased high fiber food. It can help. Drink plenty of water, exercise, just like the things we've already talked about. Symptomatic treatment, bulk laxatives, fiber replacement is definitely okay in pregnancy. Surfactants, docusate, drinking water, of course, you could throw in there too, along with docusate. It's about as effective as it is. Really, you just want to avoid mineral oil, which I don't think a lot of people use anymore. But I think I don't know if there's some, is there an old wives' tale that mineral oil ingestion helps induce labor or something like that? I feel like I heard that from a friend. That can impair vitamin K absorption, and it can cause, it's actually been linked to hypoprothrombonemia in the infant, especially if it's close to term delivery. So I probably recommend avoiding mineral oil, and I don't know, I think the idea that it induces labor, there might be other options to try there. Might induce diarrhea, so there you go. Hemorrhoids, varicosities in the anal canal caused by constipation and increased venous pressure generally. Usually correcting the constipation will help the hemorrhoids heal. Sitz baths can help. Tux pads, low potency corticosteroids for symptomatic relief might be helpful as well. There's some issue that you can consider with absorption, getting some systemic exposure. But again, steroids are thought to be, I would say I put them more on the okay side than the problematic side when it comes to pregnancy. And the odds of getting a substantial amount of hydrocortisone absorbed from a 1% hydrocortisone cream to make a systemic impact, I would say, is pretty minimal. I wouldn't put much stock in that. But you might get somebody, even an OB, who's very restrictive on that and doesn't want the exposure. I get it, but I don't think there's a huge risk there. Other anesthetics might work, like topical lidocaine or something like that might be okay. And if you're just using it topically, it really shouldn't absorb all that much. If you're using it intrarectally, possibly more so. Okay, headaches. Hormonal fluctuations would be the source of this if it's a new symptom. If it's an existing headache, the person has a history of migraines, they can definitely be exacerbated by pregnancy. Basic therapy, ice packs, rest, and acetaminophen are your likely helpers here. Now, are those all going to work for patients? No. So the question is, how do you escalate them safely? Your antiemetics are your first line emergency option once you've tried your basics. We don't use NSAIDs, so we got to go acetaminophen, and then we're skipping right to antiemetics. High-dose glucocorticoids can be useful for stopping a migraine in severe cases. And ultimately, if the pain's really bad and you want to go there, narcotics are relatively safe in pregnancy. So you could give a patient some acute dosing of hydromorphone or morphine or whatever it may be. Drugs to avoid. Again, aspirin, NSAID, especially for greater than 30 weeks. We'll talk about that some of those details here in a second. Triptans. So I sent that thing out about triptans. Remember that that's for the manufacturer contraindication. For evidence, probably actually safe to use. So, and it's a little bit of a clinical judgment call on your part, but I have some providers in the ED. So we see this quite a bit, where a pregnant person comes in with a headache or a migraine, and some of them are really comfortable using triptans, others aren't. Personally, I think with the evidence, it's relatively safe. But again, that contraindication from the manufacturer is a little bit troublesome, so I can see why people would be nervous about it. Dihydroergotamine is contraindicated in pregnancy. We don't use that. It's a little bit too potent, and there's some more evidence that it can cause birth defects, especially decreasing blood flow to the placenta. Okay, respiratory stuff. Increases in nasopharynx blood flow, so having kind of chronic congestion not associated with any allergies is not uncommon in pregnancy. Elevation of the diaphragm can cause this as well. Progesterone can cause relative hyperventilation as well, so increase some breathing things. So you might get a mixed bag of respiratory problems. I think that the difficult part here is making sure you aren't missing something like, is the patient an asthmatic? Do they have COPD history? Do they smoke? I don't know, maybe. So there's all sorts of things you should look into. And I think you would just treat it the same way as you would a non-pregnant person and then see if they apply. Most likely, let me see if I have that slide here. Yeah, so here's some options you can consider. For common cold-related things, steam humidifier, acetaminophen, ipratropium or chromal and nasal sprays can work for some of the nasal issues. Sinusitis, some medications here, augmentin, encephalosporins, and zithromycin are all okay. One of the things, we're going to get into some more ID as we get on, and we're definitely going to talk about ID next week with peds. Beta-lactam classes, so like your penicillins and cephalosporins, are generally acceptable in pregnancy. So they're probably some of the safest medications we have. So usually with pregnant patients, those are going to be right up there in the first line. Azithromycin is also quite safe in pregnancy. Now, should you treat sinusitis with antibiotics? Most likely not, but if you do feel like you need to, those are the ones that are okay. Fluoroquinolones and tetracyclines are to be used less likely in pregnancy. They're generally contraindicated, but in a really severe case, well, I won't get into that. Not for sinusitis, I'll say. Bronchitis, steam humidifier, don't treat with antibiotics. Other symptom relief options, intranasal glucocorticoids. Don't forget about these guys. You can get these over the counter now. They're really available for patients. The one problem is they take a few days to start working. So that's the drawback, but at the same time, they're relatively safe. There's minimal systemic absorption and exposure, and they do work pretty well at stopping a variety of anti-inflammatory processes. Definitely a good choice if somebody is undergoing some sort of congestion and you don't really have a firm cause for it, or even seasonal allergies is a good choice for them. Avoiding vasoconstrictors, phenylephrine, oxymetazoline, or Afrin nasal sprays, oral pseudoephedrine. These are all recommended to avoid. The alpha activity can constrict blood flow and can be problematic to the developing fetus potentially. So they are thought to be more of a risk versus a benefit. I think that you're using them short-term enough and the systemic absorption shouldn't be huge with them that from a pharmacologic standpoint, I don't really get the risk, but I have had OBs at our hospital tell our ED staff not to use them for patients who are congested. So there's that. So I kind of err on their side. I feel like they have good experience, so I trust them. But at the same time, I don't really get that there'd be that much absorption that it would be a problem. However, most people won't use them. Now, Sudafed orally, I could get that one, but the nasal sprays, I'm not really 100% on board with that recommendation. All right, coagulation disorders. We talked last week about how being pregnant in general puts you at a higher risk for venous thromboembolism. So you get history of DVT, PE. That's certainly going to put your patient at higher risk. They're probably going to require anticoagulation during their pregnancy. Prosthetic heart valve, any clotting factor deficiency, antiphospholipid antibodies, or other kind of odd things that might cause somebody to be at a high disposition for a DVT, PE. Treatment, heparin, if they're inpatient, heparin safe in pregnancy, does not cross the placenta. Subcutaneous can be used periodically as an outpatient. But more preferably, they're using low molecular weight heparin. So enoxaparin or dalteparin are the two preferred drugs, just a more convenient regimen. Sub-Q heparin for treatment, for therapeutic anticoagulation outpatient, you actually have to dose it usually 3 times a day, and it's pretty large volumes. Enoxaparin is just more convenient. It's got better kinetics too. It's more predictable peaks and troughs with it. Warfarin is category X, so we avoid it. It's a known teratogen. And new anticoagulants, I think, I want to say apixaban out of the new ones is the one that has some okay promising data in pregnancy, and maybe someday we'll see it be used for that, but right now there's no recommendation for that. So at this time, really, it's just low molecular weight heparin or heparin if they're inpatient. Gestational diabetes, first-line therapy, insulin. So some of this is reviewed, right? We talked about this during the diabetes lecture, but we'll go through it again. First-line therapy, insulin, regular insulin, NPH, and Lispro and Aspart are all the best studied. So those are the regimens we're usually going to base our treatments around. Lantus or other longer-acting insulin. So NPH is the only one that's even an intermediate up there. We don't have a long-acting insulin that's well-studied in pregnancy. Is Lantus safe in pregnancy? Very likely. It's just not studied. Oral options, sulfonylureas, especially glyburide, actually have some pretty decent data in pregnancy. There's a New England Journal article about that if you're interested in looking at that more. Metformin, there is actually not a ton of evidence out there, but there's some studies that are relatively well done that support that using it's safe in pregnancy. And I think most OBs would be very comfortable prescribing metformin to patients. All right, hypertension. Again, review way back in the fall. Dust off that hypertension memory. You have gestational hypertension, blood pressure over 140/90 without proteinuria or pathologic edema. Now, when you get more advanced, you have preeclampsia and eclampsia. So preeclampsia is hypertension plus proteinuria, and it's usually initiated by the presence of trophoblasts forming the beginning of the placenta. That's what usually causes the surge, which will have somebody neurohormones kind of going out of whack, where they have increasing norepinephrine, causing hypertension. Eclampsia is preeclampsia plus tonic-clonic seizures. So this is something, of course, that can be detrimental to the developing infant. It can be very problematic for the mother as well. We want to avoid this at all costs. We take this really seriously. We take hypertension in pregnancy and manage it pretty aggressively. You do have a 0.5 to 2% occurrence in preeclamptic women, depending on how severe it is. So it's not a huge jump from here to here, but there's enough patients that can meet this criteria that we do want to make sure we don't get to that point, or even risk that 0.5 to 2%. So that's too high, I think, for anyone's comfort zone, hopefully. Chronic hypertension, if somebody has hypertension existing 20 weeks before gestation, that's considered chronic. And usually you're just going to continue the regimen they're on. You might modify it a little bit. We'll talk about some of those options here on the next slide. You can have chronic develop into preeclampsia, of course, too. So a chronic patient might be at slightly higher risk, but they can, of course, go to preeclampsia like any patient would. It'd be the same criteria for them. Okay, this is just preeclampsia with severe features, some of the things you might look for. Not going to test you on any of this, just for your reference, in case you're curious. Okay, so how do we prevent preeclampsia? There's been some studies actually looking at daily baby aspirin starting the second or end of the first trimester. And this is contrary to what we just talked about, that aspirin is contraindicated, but the baby aspirin for preeclampsia prevention is thought to maybe have some mild benefits. I don't know, honestly, how often I see this used. I feel like it's not a common thing. And really what it's doing is you get increased platelet turnover with preeclampsia, so it's inhibiting the platelet activation process, decreasing your clotting risk. You do have some increased thrombogenicity with preeclampsia, as well as increased seizure risk. You would DC it 5 to 10 days prior to delivery, and most of that's due to bleeding risk with the platelets. So give that aspirin plenty of time to wear off before you deliver. Mild to moderate, deliver the baby. If it's appropriate, you want to get rid of the placenta and the baby as soon as possible, and that should hopefully fix your problem. However, in the meantime, you're probably going to have to do some things. So there's a couple options. Mild to moderate, methyl-dopa is this old drug that's kind of a clonidine analog that's safe in pregnancy. I don't really see this used very often. Honestly, labetalol, hydralazine, and nifedipine are much more common choices. Labetalol and hydralazine both come PO and IV, which gives them a really nice use in this specific indication because you can give it either way, for IV for more severe cases, oral for less severe. Nifedipine actually has some interesting data. There's not a ton of pregnancy-related data with it. However, it gets used a lot in this situation. So there's some cool articles that show that oral nifedipine actually has as fast of an antihypertensive effect when taken orally again versus IV labetalol, which kind of makes me wonder, I'm like, well, how is that even possible? But actually the studies, there's a couple head-to-head trials, smaller groups of patients, like 60, 50 patients, but they're pretty consistently showing that that is the case. So interesting medicine, I think, but just FYI there. So we do see nifedipine used orally a lot in this case. Nifedipine doesn't come as IV. Avoid ACE inhibitors and ARBs. Those are contraindicated in pregnancy. If you don't remember that, you should now. We'll probably be on the test. Severe treatment, high-dose magnesium sulfate IV. So this is our preferred choice. We just slam people with really high amounts of magnesium. I didn't put any monitoring parameters on here. They do monitor the levels to make sure they don't get way out of whack, but that is the drug of choice for our preeclamptic patients. So for seizures, we talked a little bit about benzodiazepines and other things like that as far as acute anticonvulsant effects. Magnesium has actually been shown clinically to be better than benzodiazepines for pregnant patients who are preeclamptic for preventing seizures overall and actually stopping seizures at the same time. The reason is you get peripheral cerebral vasodilation, blood-brain barrier protection, and it generally seems to work, has anticonvulsant properties when you give enough magnesium. Kind of an interesting use of magnesium. We don't really see that anywhere else. You don't use magnesium for seizures outside of OB. It's really the only place they use it for. Should we? I don't know, maybe, but we don't yet.
So if you're referring to this for use in preeclampsia, you're assuming they have not had a seizure, you're just really trying to prevent.
Correct, exactly.
So
Yep, so you get somebody up who meets preeclampsia criteria, really high blood pressure, they'll maybe try and get them down on one of these drugs again. If it's severe enough and it looks like they might be going that direction, not responding, they'll start magnesium.
is it used also if they do come in with a seizure?
Yep, absolutely. Yep, that's the first line. So they'd go straight to magnesium if they were seizing. Yep.
Okay.
So if you have like a mom who's an alcoholic who's pregnant, would this be what you use to prevent withdrawal seizures? Like if she stops using alcohol?
That's a good question. I think you would probably concurrently run like a protocol of some kind of withdrawal protocol and make sure she was getting diazepam or lorazepam as well. You want to, yeah, it's a little bit different mechanism. I think you get some protection from here, but you probably want to make sure you have benzodiazepines available as well. It does happen actually. I've seen it every once in a while. You see a few people up on the OB units with the MINDS protocol going. Midazolam, lorazepam are options as well, so that's kind of like your second line. They should be available, but again, magnesium's the workhorse. I feel like our OB unit rarely ever gives. They're on their order sets for preeclampsia, but they rarely ever use benzos, unless it's, again, a specific reason. But magnesium's the definite workhorse when it comes to seizure prevention and seizure treatment. All right, for chronic patients, just to review this quickly, methyl-dopa, and not the most common one used anymore, but it's an option. It's probably the weakest potency antihypertensive on this list. Beta blockers, labetalol's got a lot of good data again. It works great for the acute phase, like we talked about here, but for chronic, you can certainly use it as well. Calcium channel blockers, again, not really well studied, but nifedipine gets used all the time. It's widely thought to be quite safe in pregnancy. And then hydralazine. So not really our preferred first choices, right? You notice there's no thiazide diuretic on here. Our ACE inhibitors are contraindicated. So we're really looking at calcium channel blockers maybe as the better tolerated class. Certainly if somebody's on a beta blocker, switching them to labetalol would probably be the safest option to do. But getting them on some kind of a regimen that works in this category for chronic hypertensive patients. All right, so that's sort of my, in a nutshell, things that affect pregnant women that we haven't really dug into a ton, or some of the stuff we've touched on just to review it. Any questions before we take a quick break, and then we'll talk about the perinatal processes. All right, let's take a 10-minute break, and we'll finish up. Alright, so perinatal stuff is we're going to go through the labor process and talk about where drugs might fit into it. So we'll start with the early end of things, preterm labor. So term labor is defined usually as 37 to 40 weeks gestation. Preterm would be uterine contractions and cervical changes prior to that 37-week mark. So you can try some non-pharmacologic things like bed rest, hydration. If somebody's still smoking, so stopping can improve that situation. Prophylaxis, IM progesterone once weekly between 16 and 36 weeks. A product called Makena, which is a hydroxyprogesterone, it's a synthetic progesterone. That could be given to somebody who has a history of preterm labor with a previous pregnancy. And progesterone suppositories can also be used as well. They're intravaginal. Otherwise, you're looking at trying, so that's prevention. Not a ton of options there, and that, of course, you'd have to know your patient had that history. Tocolytic medications are overall medication class that inhibit uterine contractions. That's the goal here. So if the cervix is dilated less than 4 centimeters and membranes are intact, you're probably going to try a tocolytic agent if you're before 37 weeks. Depends. Sometimes they might just go ahead and induce, but that probably depends on, again, how dilated the cervix is and what the membranes are looking like. So, terbutaline is a beta-2 agonist. It relaxes bronchial and uterine smooth muscle. It doesn't really affect the heart too much. It's mostly selective, but it can have heart rate and cardiovascular effects. It's a commonly used medication. It's an old medication. It's not actually FDA approved for this indication, though. Shocker, right? All our pregnancy stuff, there's very little FDA approvals for a lot of things we do, but we do it anyway. Maybe given IV or sub-Q. There's an oral product out there that has a lack of efficacy. It just doesn't get absorbed fast enough or seem to work as well for this. You can't really use it for more than 48 hours. It does increase the heart rate over time. So in short doses, one-time doses here or there, it can be relatively safe, but you do get those effects over time using it. And hypotension, tremor, nervousness, angina can be some effects you might see as well. All right, that's not a super common one. I feel like the ones on this slide are getting more into what we see used more often. Magnesium sulfate inhibits uterine activity by antagonizing intracellular calcium contractility. So again, preventing the uterus from contracting. We also, of course, just talked about with eclampsia. It has no minimal glycemic effects. Some of these drugs might cause changes in blood glucose. So if your patient has gestational diabetes, we might consider using something else or something like magnesium that has a minimal effect on the glycemic glycemic level. I don't know. I'm all over the place today in my thoughts. Okay, indomethacin inhibits prostaglandin synthesis. So prostaglandins contribute to uterine contractions. Another mechanism, it's an NSAID. We've talked about indomethacin before. This is probably one of the only areas indomethacin is regularly used. It's also got some good evidence in gout. So if you think about indomethacin as gout and tocolytic drug, then that's about all it ever gets used for. So available orally and as a suppository. You can, either way, it's supposed to absorb systemically, so that's the point of this. Platelet or bleeding problems are possible. Hepatic renal dysfunction and GI ulcer. So if you're close to that 32-week mark or over that 32-week mark, we actually don't use it. I'm going to talk about the specific reasons why in a second, so hold on to that. And we don't use it for more than 72 hours total. Nifedipine is a calcium channel blocker that we talked about already that also helps with the hypertension side of things. So if you have a patient who's hypertensive, nifedipine can be really handy. It does prevent uterine muscle contraction as well. Give it orally. Again, pretty safe for the most part. So what exactly do you do and what's preferred? Usually if somebody's going into labor 24 to 32 weeks, indomethacin is the preferred agent. It's probably thought as the most effective one. However, once you hit that 32-week mark, it gets a contraindication. Part of that has to do with developing fetus. There's some risk bleeding as well. We'll talk about that specifically here in a second. Second line would be terbutaline at 32 to 34 weeks. Usually you would use indomethacin exclusively in those early phases, and then terbutaline would be maybe an option for somebody if nifedipine is not working. Once you get past 34 weeks, it's probably going to be an induction. It's difficult to say, and it could be the OB's choice on that, but that's usually what's going to happen. So that's why I don't have anything beyond 34 weeks there. Okay, so if we want to induce labor, possible indications, severe maternal infections, uterine bleeding, preeclampsia, diabetes, macrosomia, so they know that the child seems measuring large, which the science behind how they measure that has always baffled me a little bit. But maternal renal insufficiency, premature ruptured membranes after week 36, evidence of placental insufficiency or over 42 weeks pregnant. So the drugs we use to induce people, oxytocin, pitocin, by far the standard of care here. Drug of choice for labor induction. Oxytocin is a naturally occurring hormone. It's what causes contractions to happen on their own. Your body releases it, and this is just supplying your body with what it's not doing. So if your provider thinks you need a little kick, they'll give you oxytocin. From what I heard, it's actually quite painful. It does induce very powerful contractions, a little more intense than what your body would do on its own. Stimulates uterine stimulates the uterine contractions. The mechanism activates G protein coupled receptors that cause intracellular calcium increases, causing contractility. It also increases local prostaglandin production. So again, kind of the opposite of what the drugs we just mentioned are doing. It's IV only. Risks cause uterine rupture, uteroplacental hypoperfusion, so you can cut off blood supply to the placenta. It's not a huge deal because this is going to be hopefully a fast process once you start inducing labor. Fetal distress from potential hypoxia is another risk too. So you have a small window of time to get oxytocin working, and if you don't, if that's not working and you really want to deliver, like if you're meeting some criteria that's causing the fetus or the mother danger, then you're probably looking at C-section at that point. Methyl ergonidine is a second line. It's an ergot alkaloid that increases tone, rate, amplitude of contractions and causes powerful sustained uterine contractions, similar to the way oxytocin does, just a different drug. Normally not used for labor induction. It can be, but oxytocin is just always used, and it's usually effective more often than not. So the question is, would you ever really need to go to a second line option here? Probably not in most cases. But if you did, Methergen's an option. But most likely that's going to be reserved for postpartum bleeding, as it can help cut off blood supply to the placenta, where the placenta was previously, and that can help decrease bleeding. All right, prostaglandins, the dinoprostone or Cervidil is actually pretty frequently used as a prostaglandin E2 vaginal insert. It actually comes as kind of like a mesh and it's frozen. So when it gets to room temperature or body temperature especially, it dissolves very quickly. So it works fast. It doesn't take a while for it to melt and to get absorbed. You apply it directly to the cervix. May get uterine hyperstimulation or abdominal pain from that. You're probably going to get that from any tocolytic agent. That's the goal, oftentimes. Misoprostol or Cytotec is another product. It's actually a tablet that you put in vaginally. So it's a vaginal tablet, and it induces labor. It's another prostaglandin type product. You can actually use very high dose misoprostol to cause abortions or prevent hemorrhage. So if you heard about really high dose prostaglandin, misoprostol is likely the agent that they will use sometimes to induce an abortion. But it also works quite well for preventing hemorrhage postpartum. Okay, postpartum hemorrhage. Already talked about most of these drugs. Oxytocin, primary agent here. So in addition to causing increased uterine contractions, oxytocin causes the blood supply to really clamp down at the end. So actually it's pretty standard of care for every pregnant patient once they've delivered, whether it's vaginally or C-section, they're going to get a bag of oxytocin infused. That's to prevent any type of postpartum hemorrhage from occurring. It's usually fairly effective in doing that. The oxytocin's running where it's finished, and you don't want to redo it or give another dose of oxytocin. There's a couple other options we can try. So Methergen is one of the ones we can do. Misoprostol, just talked about that as well. And carboprostatate, a different one. It's another prostaglandin analog, and it can cause a couple of different effects that I put there. But basically, it's really used medically as sort of a third or fourth line agent for postpartum hemorrhage. Again, your most common drug is oxytocin here. So if you remember oxytocin is your primary drug of choice, that's where you go. But you do have these second, third, and fourth line options that are usually spelled out on order sets for OB. It's not super complicated to order them or manage them, and it's designed for nurses to be able to manage the protocols. So if their patient is bleeding, they give oxytocin, then they go to misoprostol next, then methergin's third line, carboplatin's fourth line. So it'll tell them how to sequentially go down and which one to pick there. Cesarean bleeding, obviously from a surgery, might require more procedural type solutions if it's the incision site, right? So different bleeding sources. Okay, pain management. So during labor and delivery, narcotics are okay. So most medications that aren't narcotics aren't going to do anything during the actual labor and delivery process. NSAIDs and acetaminophen can be helpful postpartum, but trials just show that even like ketorolac does really nothing to contraction pain during a labor. So epidurals are the popular choice. I'm sure everyone's pretty aware of these or knows about them to some degree. An epidural usually contains 2 medications. Well, it should always contain 2 medications, but it's going to be the most commonly probably ropivacaine, which is a local blocking agent. So it's going to block nerve impulses. And usually that's going to happen from the waist down. That's the idea. So your top's not going to feel any different. Maybe kind of mid to lower abdomen is where you might feel the numbness going in. But you can usually move your legs a little bit so you aren't like paralyzed completely, but you'll feel kind of numb or like your feet are asleep potentially. If you're really numb or can't move your legs at all, the ropivacaine is probably a little bit too strong. But ideally, if it's done correctly, it's a nice numbing agent. That's going to be the majority of what's blocking the pain sensation. So that's going to really cause the contractions to almost feel like they're non-existent. Or you feel the contractions, but the pain associated with them should be a little bit more like a pressure if it's done correctly. The other thing that's included in an epidural is a opioid like fentanyl. So this gets into a little bit of anesthesia, but what the point of an epidural is you're infusing into the epidural space. Now the ropivacaine sits there nicely and doesn't really go anywhere. Now the opioid is lipophilic, so fentanyl will go actually out of the central nervous system, out of the spinal, out of the epidural space, and into systemic circulation. So basically you just get a little bit of a fentanyl kick with this, so you get a decreased perception of pain. So you get 2 mechanisms. You have the epidural, which you have the local blocking agent, which is doing the majority of the work here. Then you also have the opioid on top of that. It's a pretty small dose of fentanyl, all things said and done, compared to like if you're getting a fentanyl infusion for like some sort of irretractable pain or sedation or something like that. Yes?
Why don't they just do the local?
They can in some cases, but I don't know if it's just the evidence supports the opioid on top of it or what it exactly is. But, I don't know if evidence says that local is just not quite enough to really control pain like they want to. I don't know if I've had somebody request, I don't know. It's an interesting question if people will request that, if they'll do it or not. We do have them available, I just don't see them used all that much. Usually they use them more for surgical procedures where they're trying to block a specific limb or something like that. Intrathecal shots. Couple options you can do here if you don't want to give a continuous infusion, or if you don't have time to set up an epidural, but you can get an intrathecal shot in. You can do preservative-free morphine. There's a couple morphine products, Aspermorph and Duramorph, which last really long. They're like 24-hour durations. They just sit in the intrathecal space for quite a while, and it takes them a while to fluctuate out and get metabolized. You can also use fentanyl for this purpose, but fentanyl will not last as long as morphine. Fetal bradycardia. So this is one of the biggest side effects to giving somebody an epidural. You hear people talk about you get a headache that never goes away. That's really, really rare. It's like a 1 out of 10,000 chance to get that. And if your anesthesiologist knows what they're doing, there's virtually no risk with these. The biggest problem is fetal bradycardia, which is a problem that can occur due to the just positioning of the patient sometimes. So sometimes if somebody's on their side and you move them a little bit, it moves the epidural around or the drug around in the epidural space enough so that it increases the way it's distributing so that it's not causing a lot of pressure potentially. So the patient might be putting pressure in a weird way that if you just move them a little bit, it can increase circulation so they can move their limbs a little bit more and decrease the pressure there. But we do have a medication called ephedrine. It's kind of like Sudafed. It's a very mild pressor, I would think of it like that. It increases release of norepinephrine from tissue stores, and it can cause beta and alpha adrenergic stimulation. It is a controlled substance. People make meth out of it, but it's not like a narcotic or anything. And it does improve heart rate in this case. So pretty much every epidural, you're going to keep ephedrine close by somewhere so that they have access to it quickly. So you definitely don't want the heart rate to drop too low. Post-vaginal delivery, usually for pain management, we're looking at scheduled NSAIDs. Sometimes they'll get ketorolac prior or post-surgery, but usually they switch to PO ibuprofen pretty quick. And we just started doing it where we, instead of doing anything PRN, we used to do like PRN Tylenol plus scheduled ibuprofen, and now they actually schedule ibuprofen and Tylenol alternating every 3 hours. So the idea is you always have something on board and you're not getting too big of troughs in between your doses. Whether that works better or not, I'm not 100% sure, but that's what they started doing in our Mother Baby Center within like the last couple of months. All right, talking about some infectious disease things. Everybody's favorite topic to revisit. So group B strep is something that colonizes the GI and genital tracts. About 15 to 40% of all pregnant women. Mothers are going to be asymptomatic. This is going to cause any problems for them. However, maternal colonization can lead to significant issues down the road. So infection like sepsis and meningitis are the two big ones. Usually sepsis is based on bloodstream infection, bacteremia, and meningitis would be a significant problem in developing neonate. So we take this seriously. So we try and culture all our patients at 35 and 37 weeks. Positive women will be treated with intrapartum antibiotics. You're going to start beginning at labor and ending with delivery. Penicillin, the old standard, is perfectly acceptable for this. We actually use ampicillin at our hospital because ampicillin comes in a more easy to distribute dosage form. That's the only reason. It's not cheaper, it's not more effective or anything. It's just easier to get to the floor. We have to compound penicillin. It's got short dating, all that stuff. If somebody's allergic to beta-lactams, clindamycin is considered the appropriate alternative. I've never seen anyone allergic to clindamycin, believe it or not. Chorioamnionitis is intraamniotic fluid infection. It causes maternal fevers in the peripartum period, associated with about 20 to 40% neonatal sepsis and pneumonia. It's polymicrobial, which I'll show you here in a second. It's usually due to the migration of cervico-vaginal flora and invasive procedure contamination, depending on what happened. Transplacental infections can also be possibly a cause. Diagnosis based on temperature, so fever over 100.4, treated with broad-spectrum antibiotics. So, and this is where OB gets a little weird. It's their antibiotic choices, and broad-spectrum are considered ampicillin, gentamicin, and clindamycin. 3 drugs that we don't really use in other areas that often. So again, you're looking at OB as taking evidence that's a bit older and applying it to their current medicine. Now, if somebody was severely septic or something, could you give like vancomycin and Zosyn? Absolutely. And it would cover all the same stuff this does. But these are the ones that were studied. And usually, for something like this, you're giving like 24 hours of antibiotics, and once the patients have afebrile for that period, you can just discontinue. So a lot of times these patients get like 1 dose of gentamicin. Does that cause resistance? Probably not enough to really do much harm there, but it is the standard of care. So if they spike a fever, you give them a load of Gent, Clinda, and ampicillin, and monitor them for the duration. And once they're fever-free for 24 hours, you can DC them.
Did you say you do all 3? Or
Yes, you do all 3. Yep. Mm-hmm.
You do all 3 and the group B strep.
So this would cover group B strep. So you got
But for the last slide, is that penicillin?
This is more, think about this more as like prophylaxis up to labor, and then this would be post-labor.
And are those individual, or are you doing them combined?
They're all these 3?
No.
Oh no, sorry. Yeah, this would be one. No, yep, one or the other. These are all acceptable, but it's one or the other.
Okay.
Yep. Whereas these 3, you give all of them together. Yep, you only need one for the group B strep.
What did you say for sepsis and vancomycin?
Yeah, if it's really severe, yeah, and you escalate it, like if somebody's not getting better and they get an ID consult, ID is going to come in and give them broad spectrum antibiotics like Vanco, Zosyn, or Cefepime, something like that. Most people just aren't super comfortable using gentamicin. Clinda's got iffy coverage, especially with Staph aureus, MSSA or MRSA. Gentamicin can cause renal toxicity given long term, even in healthy patients. So there's better options out there, which is why for short term these are fine, and there's good evidence with them. But if somebody's infection snowballs a little bit, we're going to switch them to something more broad. And again, this just points out your organism associated with amniotic fluid. There's a lot of different things you can see. And again, polymicrobial, so when you're approaching this, you would treat it pretty broad spectrum. Group B strep, E. coli, common things, but enterococcus, but there's a lot of other kind of odd things as well. Oh, okay. Endometritis is another cause of postpartum fever. Usually, choreo is going to happen early, so like right away within the first 24 hours. Endometritis is usually a little bit later, so day 2 or further. And usually once you're 10 days out, you're probably not at risk for anything like this anymore. Not impossible, but much lower risk. Polymicrobial, again, similar pathogens to choreo. IV clindamycin and gentamicin are the preferred agents. We kind of drop ampicillin at this point, I think, because group B strep is not usually associated with endometritis. And if it is, clindamycin covers strep too, so you cover it. The other thing is ampicillin sulbactam. If the person was group B strep colonized, it could be a contributing factor still potentially, and that's going to work well. It's also going to add on anaerobic coverage. Bacteroides fragilis is commonly associated with endometritis. It's an anaerobe that is covered by clindamycin. It's also covered by unicin. So we could do just unicin as by itself, or you could do the combo of clinda plus gen. Depends on patient. Either one would be fine in the majority of cases, though. I think our centers tended to lean more towards unicin in cases like these as opposed to combo clinda and gen. Certainly clinda and gen for a beta-lactam allergy would be preferred, of course, over unicin. So you administer antibiotics until patient's approved, afebrile for 24 to 48 hours. You don't need to follow oral antibiotics. Stop your IV course, and you're done. That's all you really need to do. Kind of odd ID, right? Torch. Not going to test you on any of these. These are an acronym that shows you some other things that are perinatal infections with similar presentation. So this would be in the immediate postpartum phase with the neonate. And so they're going to get like a rash and ocular findings that they can notice based on physical exam. And they're usually associated with these things. Most of them are viral, and we can't really do anything to treat that. So it's going to be supportive care, but it might warrant some NICU type support things, depending on how severe it is. All right. This just goes to the torch stuff again, in case you're curious. Again, not going to test you on this. And we're done. So next week, we have got pediatrics, and I don't